problems. Dr. SUVEN BHATTACHARJEE from Calcutta. So he will talk to us on the correct technique and instrumentation for anterior capsular rhexis and can opener. This is to prime you, but this is very important. And this is one talk without the BHEX ring. SUVEN will feel odd on this, but then no BHEX ring will be shown in this film.
One slide where I can
maybe even
expand the capsule.
Expand the capsule. Expand the no pupil. Let's see how we can introduce BHEX into this also. Let's see.
No, see, let's have the first slide, please. Yeah. So since I've disclosed that I have no financial interest, I can't talk about BHEX ring. You see. So okay. So let's get on with business. I'm SUVEN BHATTACHARJEE from Kolkata, and I'll be talking about capsules. I guess all of you over here who are attending the session are already doing it. So we will talk about instrumentation. Well, there are two types of instruments that we use. One is the needle, standard 1 rupee, 2 rupees needle, and the capsular rhexis forceps. So the needle needs to be bent at the tip and at the hub. That's absolutely necessary. The bend in the middle is optional. It does serve a purpose. So this is something called a 2-bend cystotome and a 3-bend cystotome. Now the purpose that it serves, though some people think it's because of the curve of the cornea, that accommodate the dome, that is not the case. The purpose is actually to maintain a steady anterior chamber. So if you do not have a curve, apparently, some of us don't use, including me, you tend to put more pressure on the posterior lip, and viscoelastic is likely to escape. So having a bend over there probably helps you maintain that anterior chamber better. Of course, there is a 2 capsular rhexis forceps, the standard Utrata, which we have seen for ages, and the Haldipurkar, Castroviejo, Masket, all modifications. But this, I think, is the one which you use. And of course, there are the micro rhexis forceps which people use. Now, this is a can opener capsulotomy. Going by the age of the video, you can make out we don't have currently anybody doing can opener. I did not have a video, so I asked Minu, and Minu also, I think, dug out some from the archives and gave me one. So that is how we just create a postage stamp, multiple punctures, and then we join those punctures and then bring them together. So that's how we have a capsulotomy. I guess nobody does it. Even for SISs, we now use a capsular rhexis, and if we need, we use relaxing capsulotomies. Now, the basics of using viscoelastic in capsular rhexis. I think that's something we must get very, very clear. You inject in the center before initiating the rhexis. The idea is to flatten the dome. The capsular rhexis will always instinctively run downhill. So you eliminate the hill, you make it a plane, you flatten it by injecting viscoelastic in the center. Now, when you have a runaway rhexis, that tear is running to the periphery. Instinctively, what we do is inject the viscoelastic right in the middle. And that is something which we need to absolutely avoid. When you inject viscoelastic in the middle, whatever it is, high molecular weight, low molecular weight, whatever you inject, you are basically pushing that liquefied cortex into the periphery and forming a donut, and your capsular rhexis is going to run further out to the periphery. Instead, go through the side port, if necessary, create a new side port and inject viscoelastic at that advancing edge of that capsular tear. That way you have more control over that area, you have flattened that area, and now you can do whatever maneuvers you want. This is a paper every cataract surgeon should have read at least 10 times. If you have not done that, you must go back. You've got no business getting into the operation theater and doing a cataract surgery. You will hear various versions of Little's capsular rhexis tear out rescue. This is the original paper, and do read it because there are some very, very vital points and you need to read between the lines. To rescue the capsular rhexis, the tear must be redirected centrally and back to the desired circumferential path. The force applied to the capsule flap is then reversed in the direction but maintained in the plane of the anterior capsule. Very, very important words. First, unfold the capsule flap so it lies flat against the lens cortex as it did prior to being torn. Key words. So let's see his original. Brian Little is a big man. He isn't a small man, and he's contributed real big. Unfold the flap, switch to the capsular rhexis forceps possible, hold the flap as close as possible to the root of the tear, pull it circumferentially backwards to the place where you came from. Then, holding the flap under tension, direct it more centrally to initiate the tear. So you are going retracing your path where you came from, the tear will predictably propagate to the center of the capsule. If it doesn't, your technique was wrong. There is nothing wrong with what we are supposed to do. I mean, you did it wrongly. So just to illustrate, I've been tearing paper since morning, and yeah, Mohammed Sai has been asking what I've been doing. That's your capsular excess halfway through. Right? This is what we call a rip. We are usually using a force like this. That's the standard capsular excess force that we're using. Now my capsular excess is running out. It's running out. It's running this way. What we are using is a stretch. I'll just use the next slide, and this is going to make it very clear. We are going to tear by stretching and not by shearing. If I would tear it like this, it would be a tear by shearing. If I tear it, hold it over here, and do this, I have predictably turned that tear. You see where it was heading. You can do that again. Try it at home. You can predictably turn it. Use stretching. I have turned it. See that angle it made. So that is essence of Little's capsular excess, and absolutely need to know that. Let's look at this small video that I had. It's pretty old. So here I had a little bit of capsular fibrosis over here struggling. That needle won't take it. I realized only over here that that's fibrous. So a little struggle, and then I gave up, and I said, okay, let's use my scissors. So it's a bit tough fibrous band over there. No capsular cortical adhesion for that matter. So yeah, now as soon as I did make that snip, it started going outwards, and that wasn't very comfortable. See what I'm doing. Hold it, go back, flatten that thing, try it, but I'm not holding it at the apex. So I need to go to the root of that tear and actually hold it, and that's when I'm going to get my, yeah, there I go. Sorry about that cortical fluid over there, but I have already turned that. So now yes, there you are. Okay, now I again go into my rip or a shearing force. And again towards the end, again the capsular excess is going to run out, and I'm going to again hold it by the ear and bring it back. Yeah, there it's going out. So I'm going to give that pull a sharp pull. Just wait for that. Yeah, there you are. There you are, and you turn it. So you can turn it predictably back. Let's try this again. Another case. This is actually towards the end that it was moving out. So yeah, so let's see this over here. It's moving out. Going there. It's still now it's controlled, and it's going to just So I just realized that. Hold it, and one tug, one sharp tug, and it is going to turn. And this is a case where I've already done my most of my nucleus removal, a bit of cortex over there, and I have a capsular excess tear over there. Now this is a little tricky. I did not want to put in the lens and then do that because I could probably let that run out further. So I'm trying over here to use that Little's maneuver. Didn't work very well. I was actually, because you're already at the zonules over there, and zonules are going to play different games over there. The zonular forces are going to act different. So I gave up over there, and I said, no, I can now do it, control Little's tear, Little's rescue by creating another cut over there. So I'm holding that. Now I have got a better handle on this, and I'm going to take this capsular excess around that tear. There you are. That's it. Thank you very much for your kind attention. I hope I've done justice.